Dr. Moha. So we just have Dr. Amardeep Gupta's talk first because he has a flight to take and it's getting delayed. And Dr. Vijay has requested that he's going to be sitting here and he's over. Thank you.
So may I have Dr. Amardeep Gupta? He is going to talk on. Do you have your presentation or? He's going to talk on the issue of why CD4 matters despite recently being sidelined.
Good evening, everyone. I'm Amardeep from India Private Limited. I want to thank the AIDS Society of India and Dr. Yeldandi for giving this opportunity to talk on the CD4 matters. So we, a company, a Japanese company, Infectious Corporation, based out of Kobe in Japan. And sorry, I will be skipping a few slides because of the time. So we have a global presence and we are basically serving hospitals, commercial labs, animal hospitals, clinics, and other research organizations. And in the Asia Pacific region, we are growing and we managed to have a manufacturing facility in 2007, and we have recently inaugurated our factory in Ahmedabad, nearby Sana, in Gujarat, for the manufacturing unit. We deal with the individual diagnostics products mainly, and we deal with the products which is related to the disease like hematology, urinalysis, hemostasis, immunology, clinical chemistry, and genetic testing. Today's topic is about CD4, so we deal with the flow cytometry product, which gives us information about CD4 count and the CD4 percentage count. And we all know about the definition of HIV and AIDS and how it goes from viral replication to AIDS. And these lymphocyte cells are associated with this. So for CD4 and CD4 percentage, we have the cyclo counter. And for other T and T cell marker, we have a flow cytometry, which is multicolor flow cytometry for. And in this, we have TB&K application, so we have an instrument. We will be soon launching another device which will give us information about CD4 and CD8 ratio, most probably by end of this fiscal year. We know about HIV disease progression, how CD4 matters, and the typical disease with the classification of WHO stage 1, 2, 3, and 4, the respective CD4 counts with the typical disease. And with respect to the AHD, which is a very important topic today, that CD4 which plays an important role in the HIV management related to advanced HIV disease, and the role of CD4 testing in this management has changed in recent years, but the recent guidelines also now strongly recommending to have a CD4 testing at the initiation of treatment and when the immune suppression is suspected. So CD4 should still continue to be tested to support the patient. And also in the HIV, advanced HIV disease, where there is a definition of CD4 cell counts goes below 200, and the other factors where we are actually well aware about these HD factors, and also about the immunological failure, which is a very important chapter to discuss about CD4 count. So targeting towards 1995 for the UNAIDS and other important WHO regulations, and we have a CD4 gateway to diagnose and manage the advanced HIV disease for the baseline CD4 test at the treatment entry point, and CD4, which is a very critical component for the AHD screening package. So why we should be CD4 should be done. It's like for early identification of the person who has advanced HIV disease and to identify the patients with treatment failure. Importantly, in case of viral load is not routinely being done, and the lower the CD4 count, the greater the risk of complication of the death. So this is the kind of a pathway which I have put across from the base CD4 and advanced HIV disease where it gets in CD4 200, and the conclusion is that CD4 is the percentage test determination is necessary for the potential decrease in loss to follow-up monitoring at least once in a year for the ART, and the supplement where viral load is not available, and the screening of the susceptibility of opportunistic infections. So we have this instrument, a beautiful instrument, very small footprint, which is a flow cytometry based instrument, which gives a very important information about the cell being for the CD4 and how we find the CD4 positive cells to get the information about the CD4 advanced HIV disease and the other very compact and affordable instrument which is cost effective for the CD4 and which determines the CD4 in the percentage with a very low blood volume and gives us of 20 samples per hour with CD4 as a kit and CD4 percentage as a kit, and we have a very simplified process, and within 3 minutes of preparation we get the CD4 and the CD4 percentage on the result on the screen, and can save those results and can take easy print out anytime and retrieve those information within the device. We can easily see where the cells are lying and locate it and to understand the other populations. So at the end, this is the information about the product what we have. And I want to thank everyone for your patience. Thank you so much.
Thank you, Dr. Gupta, for the updates on CD4 testing.
Thank you.
I think we should move on to the next speaker.
Yes, thank you very much. I just request you to hand over a token of appreciation to Dr. Gupta. Thank you very much.
Next, I would like to ask Dr. Anuradha regarding the current scenario about the national response to the HIV epidemic. I request you to focus more on the care, support and treatment related issues.
Good evening, everybody. Thank you, Dr. Pavan, and thank you, the organizers, for having me here on this panel to talk about the national response to the HIV epidemic, especially in light of the care, support and treatment divisions. Though the program started way back in the 90s, 1991 was when it started, but the care and support division really came into force in 2004, 1st April, when the first 8 ART centers were established across the country, and mine was the first one of those 8 centers to be established. And from 2004 April 1 to where we are now, it has been a very remarkable journey of antiretroviral treatment, of patients, of their recovery. I still have patients whom I saw before 2004 also who are still alive and doing very well. And so that has been the most remarkable part of that journey. And I have grown with the program and I have evolved with the program, and Dr. Guha and I have been there from the beginning itself. When we started the first patients on SLN, stavudine, lamivudine and nevirapine, 30 and 40 depending upon the body weight, and we started with stavudine based program with nevirapine as our NNRTI, and though stavudine SLN had its toxicity, I'm not saying it was not a toxic program, it was far more better accepted early as compared to ZLN, because those were the two drugs, those were the two ART that we used to prescribe, ZLN and SLN. And all ART initiation was CD4 based. We just talked about CD4. At that time, without CD4, we would not have started ART. It was less than 200 when we used to start antiretroviral treatment, and the CD4 was the basis, or a clinical WHO staging, the basis for starting antiretroviral treatment. Over time, we have seen so many toxicities with those regimens. We saw neuropathies, we saw severe lipodystrophy. I have seen patients die after a single dose of SLN because of SJ syndrome developing because of the nevirapine. Single dose, one dose, and third day later the patient has succumbed to the injury. So they were toxic regimens, and as time went by and as more and more evidence collected, and based on the scientific evidence that was collected, the program also evolved. The program changed, we evolved, we have more higher CD4 counts from 200 to 300 to 350, then we went up to 500, and of course recently the WHO also has recommended, and the country has also adopted universal antiretroviral treatment for everybody who is HIV infected, without, irrespective of CD4 count, clinical stage. And so now it is universal antiretroviral treatment starting for all patients. And so that has been one very interesting journey of starting ART. And over the period of time, we have seen how the population and demography of the ART center has also changed. We used to have very young patients who used to come to our ART center. Most of our PLHIV, when we started our work, were less than 35. Now today morning also we had a very nice session on HIV and aging. Today more than 35% of my clinic is PLHIV who are more than 50 years of age. And so now we are dealing with other comorbidities. We are dealing with diabetes, with hypertension, with multimorbidities. We talked about polypharmacy, frailty. These are all issues, and these are all problems that are now our patients are facing, and we have to engage with that population and with all those problems. Neurocognitive decline. We are seeing patients with hand. We are seeing patients with PML also. And along the way, we have also the program also evolved from 8 centers. It has the program upscaled to such a large extent that now there are more than 700 functional ART centers across the country. I think there are 730 odd centers that are functioning. They are dispensing the same kind of care across the country to all patients, all PLHIV who access services. We have integrated HIV and TB services so well that TB treatment is now available within the ambit of the HIV or the ART centers itself. So patients don't have to visit 2 centers. So that has been one integration. Now our patients are also able to access hepatitis C treatments. And like we also had a session on hepatitis C management, hepatitis management. So hepatitis C is also being taken care of for all our patients. Now with the newer guidelines for advanced HIV disease, we have also incorporated within our newer TRG how to treat and how to diagnose cryptococcal meningitis and cryptococcal disease in our patients. So the program has evolved tremendously. We have started with first line, we went on to second line ART in 2008. That used to be also, that was quite a challenge, how we used to diagnose based, we had criteria, CD4 criteria or clinical criteria for diagnosis, suspicion, then we would confirm with a viral load. But now we have moved towards uniform or universal or viral load testing for all PLHIV who are on ART from first line. And so we are able to detect and diagnose virological failures much earlier. Now we have moved on to a second line ART, we will have a third line ART. Now that we have probably moving on to genotypic resistance testing as far as the program is concerned within the program. So these are all aspects of the program. The program is very well developed, it's very well organized. It has grown a lot. There is a lot of scientific basis on the basis of which the program makes decisions. Dr. Guha here is the chair of the TRG for adults on ART. I am the co-chair, and so we have had very lengthy discussions in our TRD sometimes. When we transition from SLN, ZLN to tenofovir-based regimens, I think that was one of the most longest TRGs that we had when we took that decision to transition from stamidine, zilobodine into tenofovir-based regimen. Then we adopted TLD and dolutegravir as our first line. That was another important decision that we took along the way. Now TLD is part of our first line regimen. Dolutegravir is part of our second line also, or third line also. We've introduced a very remarkable pediatric ART program, and there are many children in our country who are on HIV, children living with HIV. We have not been able to achieve complete elimination of mother-to-child transmission, but we have achieved tremendous success. Earlier, my pediatric ART clinic used to see many new infections in children. Now, new infections who present to the clinic are so rare. It's a very unusual feature to see a newly diagnosed child living with HIV. So that is one of the remarkable achievements of the program. Again, PPTC, but that's because of a very effective PPTC program where we are screening all our antenatal mothers. So these are some of the successes of the program. There are challenges. One of the biggest challenges is retention in care, and I think that is something everybody faces. Many patients, there are problems with adherence, problems with retention in care, problems in tracking back patients. So these are challenges which we are facing. Then multi-morbidities, our patients are growing older, and so how to incorporate it? The program has recently started moving into integration of the non-communicable diseases program of the Government of India and the ART program, and we are now implementing integrated services of the NCDs as well as the HIV program. And so that is another step that the program is going to take as we go forward. So there are some challenges. We know how we need to go forwards with it, but these are some of the milestones that we have achieved in this program. It has been a remarkable journey for me also. When I started with SLN 30 and where we are now today, I think it has been a wonderful experience.
Now, Dr. Vijay, since you are also a member of the TRG for ART for adults, so whatever Dr. Anuradha has said, if you can add on to certain issues and challenges that still the program is facing, if you can.
Thank you very much. Before I go on, in the interest of full disclosure, I am, since 2005 to date, funded by the United States Centers for Disease Control and Prevention. So all of the work that I do with NACO is done actually by around 400 of my associates. I just take the credit for all the hard work that they do. And I participate in the TRGs and make a lot of noise in the adult pediatric as well as lab TRGs. So I think that one of the perspectives that I should bring to your notice is that very early on, 25 years ago, I used to be what they call the American migratory bird, that flies into India, squawks a lot, eats the best food around, shits all over the place, and then squawks a lot and flies up again. So starting from there, but I did drag Dr. Yeldandi to the first HIV conference in Andhra Pradesh and Hyderabad, along with Father Tommy and a whole bunch of other luminaries. So Dr. Yeldandi has seen me grow old. So in terms of the national program, I will tell you that when I first started, I was optimistic that the solution to these problems will be found in India by Indians. And really, today I'm confident because over the last 25 years, what we have seen in the public health program is nothing less than extraordinary, which is why I call NACO one of the exemplary public health agencies in the entire world. Specifically, as a clinician dealing with HIV, my constant concern when I came to India was I didn't have laboratory support to back up what I was saying. And I said, look, I don't practice voodoo. I cannot touch a patient and say, you have this, that, and the other. I need a complete laboratory evaluation. I need imaging. I need CD4. I need viral load. I need a credible antiretroviral treatment program. I need to build a team which has a skill set to do all of that. And very quickly I realized that rather than be a clinician, I should transition to being a public health person, devoting myself to implementation science. I don't make policy. The National AIDS Control Organization makes policy based on a lot of input and scientific evidence given by a lot of people. But what we do par excellence is implement those policies. So we take an abstract policy and make sure it becomes a tangible reality. So what has been accomplished? Well, our first accomplishment was CD4 testing. We standardized the entire CD4 testing and made sure that sitting in Hyderabad, an entire transport system was developed that assured people access to quality testing in CD4 in less than 36 hours. The CD4 result was in the hand of the clinician as far away as 500 kilometers from the central laboratory. And that was done in the lab that I created about 17, 18 years ago. And we also created the transport system, the biohazard safety and the temperature controlled safety transport system that was adopted by NACO for the rest of the country. But probably my most gratifying moments were when we could persuade Dr. Revari that stavudine-based regimens were actually a curse, not a cure for people with HIV, and we needed to move to less toxic regimens. And finally, now we are seeing universal adoption of an INSTI-anchored regimen, which I think is great progress. Secondly, let me tell you about ensuring, and this is, I think, where you should really, really acknowledge NACO's performance. NACO said, we just don't do testing. We will set up a system of testing which is available at an reliable quality for everybody all the time. So there were initially 64 high throughput viral load testing labs set up throughout the country, which is what my team had to set up. Now there are about 85 odd labs. And this entire system does more than 100,000 viral load tests per month. That is unequaled anywhere on earth. There is no public health system that has that volume of viral load testing. And there it is quality assured. The rejection rate of any specimen coming for testing is under 2%, and the reliability is virtually 100%. Most of the labs are accredited by the NABL, and we have an entire peer system for both proficiency testing and quality enforcement, and it's all automated in real time. And somebody can sit at NACO, as Dr. Das does, and in real time he can see what's happening in 5,500 sites throughout the country in real time. So I think in the future we will have drug-resistant testing. That technology will be based on sequencing, NGS. And the reason we wanted NGS rather than PCR is we wanted to know, or we still want to know, what is the background of all of the viruses circulating in India in different parts? What is the background mutation rate in treatment-naive people, in people who are treated, and people who are failing treatment? So that is in process. It will be set up at AIMS and NIMHANS. NITPA already has a biorepository which will bank all of these different strains. And I think that this is the kind of database that will allow us to do machine learning and do a lot of predictive analytics in the future. So we've come a long way. I've been a witness to history being made in this country. I consider myself very privileged to have the ability to come and work with all of you. This has been an extraordinary conference, thanks to Dr. Jalada's leadership. And once again, thank you very much.
Thank you, Dr. Vijay. May I request Dr. Pavan Duggal to highlight the issues of HIV/AIDS Act 2017 that we were discussing since yesterday morning. Let him finish, then we'll have.
Chairperson, ladies and gentlemen. It was middle of December 2024. The winter had set in Delhi, and it was very cold. And I'm talking of a new call center that had been set up in Gurgaon. It had about a strength of 4,000 employees who were working in different shifts. And they had recently recruited about 800 new employees. One of those employees was a bubbly 26-year-old girl called Aparna. Aparna was the life and blood of the office, very popular. One day while she was on the job, she vomited, she fainted while being on duty. Well, the management took her immediately to the hospital. She was tested, a couple of things were done, some medicine was given and she was told to go back home and rest. 4 days later, the reports came in directly from the hospital to the company. The report stated that this girl, Aparna, was HIV positive. The management decided we are a US-owned company. We don't want to have HIV people in our office. So they called an office meeting, told everyone, we've got Aparna and she is tested HIV positive, and we don't want HIV positive people in our office. So can you please encourage her to resign? People started gossiping, not many people didn't come forward, and lo and behold, after 10 days, the management gave her a notice saying, sir, madam, we don't really want your services because your presence is not conducive to the work environment. Meanwhile, the management also called up her landlord at his phone number, saying that she's been tested positive and that he better will take care. Consequently, the landlord started pressurizing Aparna to vacate the apartment. Having left it no other options, Aparna approached the local police. The local police said, this is not our big concern. You can give us a complaint, we will not be looking into it. When she found that she had no other remedy, she came on to us, legal advice. I examined her and said, look, you are actually sitting on a mountain of contraventions of law. And if you want, you can take these guys to the cleaners. So we gave her legal advice, but I want to pause here. What exactly did go wrong in this Aparna's case? Was what happened legally okay? Or was it not okay? Anybody in the audience?
Not okay.
Not okay. Why not okay?
The report was given to the office, not to the her.
The report was given to the office, not to her. The report was communicated to the office in writing on email, which is unencrypted. The report did not have her consent. That please give my report to the office. The office was insensitive enough to call a meeting of the office staff. And the confidentiality of Aparna and the health status went for a 6. They openly declared to the entire employees present, we don't want this lady. Can you please ask her why? Because she has tested positive. On top of it, when nobody actually forced her, they meanwhile, in order to put pressure, called up the landlord, putting him in a state of panic. He got activated. He asked her to vacate. Meanwhile, when Aparna was adamant and not wanting to move out of employment, they asked to be terminated. So that was a number of controversies took place. All that took place because of the law that's prevailing in India. And I think as ecosystem stakeholders, we need to be aware of what this law is. Why do we need to be concerned about HIV Act? And how does it impact the ecosystem and stakeholders? So in this context, I thought I'll quickly run you through. But before we do that, I want to really take you through this story. Can somebody help me please? I try to keep it across. Okay, thank you. But before we go forward, I want to take this opportunity to give my salutations and regard to the remarkable contribution that's been done by my friend Dr. Anuradha. Well, way back in 1989, we had gone ahead and raised this entire issue for the need for having a legislation. Way back in 1991, he was in touch with the Indian Parliament, asking them to come up with a new legislation. And thanks to the repeated crusading impact and efforts of Dr. Gujarat, we actually saw this legislation finally fructifying in the form of the HIV Act 2017. Now, when I look at the preamble of this law, it's very clear. It wants to prevent and control HIV/AIDS. Sorry. It wants for protection of human rights of persons affected by HIV/AIDS. It wants for more effective care, support, treatment. It wants to secure the rights of the healthcare providers and other stakeholders. And it wants to fulfill India's international obligations under the UN Declaration. Well, some classical legal definitions given for the first time under the law, including what's AIDS, what's HIV, what's HIV positive, what is an HIV infected person, and a healthcare service provider. And mind you, healthcare service providers are not just doctors. It's nurses, it's paramedics, it's psychologists, and other professionals involved in HIV/AIDS care and prevention. So clearly, the law does not want you to discriminate. People who are HIV positive are not untouchables. And the law is giving you a crystal clear message. Please don't take them as untouchables. You do that at your own peril because you will be in a ring of fire as you go forward. And therefore, if you are going to create an unwarranted ecosystem, an environment, then you have to face the consequences. That's the reason. Under Section 3, the law says no person, and the word is no person, shall discriminate. It's mandatory. You don't have the discretion against an HIV positive person. In regard to what? In regard to employment, of healthcare services, education, public services and accommodation, right to movement and residence, insurance in HIV testing. Well, you are specifically prohibited from doing certain acts. You will not propagate hate against HIV positive individuals. It can be through spoken or written words. It could even be by symbols, by signs or visible representations. It could be by advertisements or public broadcasts. You cannot promote hatred or discrimination or encourage physical violence against HIV positive persons. And you have to ensure that they are able to enjoy their dignity and non-discriminatory treatment, living like others in this ecosystem. First and foremost, the HIV positive person is the center of this new universe of the HIV law. Why? Because you will now have to get the consent of the said person. First and foremost, you cannot conduct any test or medical intervention without informed consent. So it's not just ticking the box, please sign this. No, it's not that. The Supreme Court says informed consent means consent which is free, fair, unequivocal, and which is given after understanding the legal ramifications of their own. And who has to provide the consent? The concerned individual. You can't say, well, he gave me only consent. The law says I'm not bothered about your consent. You'll have to get consent in respect of pre-test counseling and even post-test counseling. And ultimately, the law is wanting to protect the rights, the confidentiality, and the dignity of affected persons. Well, majority of the lawyers will have to have informed consent for HIV testing. But certain exemptions are there. If a court orders, it's necessary for it to be done, or it's in pursuit of an investigation or trial, or for medical research or therapy, then informed consent need not be given. You're well within your force, provided you are fortified by these grounds in the law. But then you will still have to ensure that the donor must receive post-test counseling before knowing results. And it could also be necessary in the interest of public surveillance. The government will want to get this testing done for a variety of government purposes. So for that, informed consent is not necessary, but confidentiality is going to be crucial. So you cannot force another person to disclose their HIV status. This can only be done if a court order says, in a legal case, please disclose, and then you disclose. Otherwise, you can't put a column into your interview box or your interview letter saying, tick mark to say whether you are HIV positive or not. Further, when you are holding such responsibility or such information as an employer, you are doing it in your capacity as a physician. And therefore, the law wants you to update and uphold the confidentiality. Of course, disclosure can be done if the concerned person gives you informed consent in writing. If he does not give consent in writing, you disclose, you run the risk of fire because you face the legal consequences. Of course, certain exceptions to be given because if the health care providers are sharing information for treatment, there is no need for informed consent. If the court orders there, no informed consent. Legal proceedings, no informed consent. Do you think the HIV positive person should not have any responsibilities? Sorry, the law says no. Even an HIV positive person will have to have various duties that he or she will have to mandatorily follow. And these are various duties. They will have to exercise precaution, prevent transmission. They will have to contribute to risk reduction strategies. And in case their action is going to lead to violence or vandalism to harm, then appropriate action is to be taken by the government. Well, from the perspective of establishment, now you guys are medical guys, right? You're all doctors. While I'm happening this, I want to tell you that on the 11th of August 2023, the Government of India has passed a new law. It's called the Digital Personal Data Protection Act 2023. The Government of India has now published the draft Digital Personal Data Protection Rules 2025 for public comments on their website the 5th of March. These rules are categorically telling you, you guys will have to take, apart from this informed consent under the HIV Act, you'll have to still give them additional notice to them, because you will be collecting their medical data, which will be their personal data, and that can only be collected if you give a notice in writing that this is the particular purpose for which you want to collect their data and get a written informed consent. Once the consent comes in, you can collect data, otherwise not at all. Not even for medical research purposes, because that's not going to be exempted as of now yet. Parliament has been given the power to exempt, but right now the power is not gone. So I think the government is focusing that you will have to do a multiple variety of compliances. One under the HIV Act, one under the Digital Personal Data Protection Act, and since you are ultimately collecting data in the electronic format, you are governed by the Information Technology Act 2000. You are not doctors or medical institutions. You become intermediaries and network service providers, because ultimately you are saving electronic information in the form of medical records of patients. That's third-party data that does not belong to you. You deal with that particular third-party data in your capacity as an intermediary. And that means so, you are required to exercise due diligence. So as medical practitioners, as medical institutions, who are now going to be straddling with numerous compliance requirements. One under the HIV Act, one under the Digital Personal Data Protection Act 2023, one under the Information Technology Act, one under the Information Technology Rules 2021. So be prepared for the new set of exposure to compliances. Well, the government has taken this HIV law to be a welfare-driven legislation. And therefore, it's come up with various provisions for welfare schemes for HIV-affected persons. It is provided for protection of property for HIV-affected children, and it's provided for provisions for creating more awareness and education programs as we go forward. Particularly in the context of women and children, the law has taken a specific soft position. They want specific care for children with HIV and AIDS, and the central government has been given the power to come up with guidelines against that. But there are specific counseling and information provisions for HIV positive women have been provided. Even the protection of reproductive rights of HIV positive women has been specifically protected and safeguarded under the new law. Well, the law wants a safe working environment for HIV positive individuals. And to that particular thing in mind, the law has stipulated a variety of these obligations which we can have a look. So if you are an employer, think again. You just can't wish away an HIV positive person. You have to do various obligations of compliances. You don't do that, you actually commit an offense, punishable with imprisonment and fine. Yes, it's a bailable offense, but nonetheless you can still be arrested. Nonetheless, an action can still be taken. So therefore, I think the focus will now have to change more towards a more compliance-oriented mindset as we go forward. Well, the law talks of appointment of an ombudsman who will be given the power and duty to go ahead and adjudicate any disputes pertaining to non-comprehension of the provisions or comprehension of the provisions of the HIV Act and providing appropriate remedies to affected persons. Well, you can file your complaint in the ombudsman. Ombudsman has been given a limited period of time, and within that period of time, the complaint has to be done and completed. If you don't complete, and then action can be taken against the person. So it's like a unique situation where institutions and medical practitioners, we are in the center of the digital commercial warfare. We are being surrounded by exposure of 360-degree viewpoint. So while we go ahead and give our duties towards protecting and preserving the rights of HIV positive individuals, we also have a primary duty to our own selves to protect ourselves from exposure to legal consequences. Because once you get sucked into this whirlpool of HIV Act, of the DPDP Act, and the VIP Act, I can assure you, for the next many years, it's going to be a humongous new headache for you individually, for your institutions, as we go forward. Needless to say, you will have to take various confidentiality and safeguards for HIV positive. Finally, I will advise, don't be born into this exercise where it's only about 2 years ago. I can do the Indian Gujarat School of Management and practice. Guys who are wonderful at managing medical conditions. I can assure you, 10 years as a lawyer, you may not be very wonderful in managing the legalities of these nuances. Because once if you would be managing those legalities, you have to create false electronic records. Under the new criminal law of the country, the Bharatiya Nyaya Sanhita 2023, you forge electronic records, you get 7 years jail time and fine. So it's actually playing with fire. A lot of penalties are there. I think the law would have done much better if more stringent penalties would have been given. But then, on the other side of the spectrum, most of the people are complaining that this law is not working. It's not being invoked properly. It's not actually being implemented on the ground reality as we go forward. So I think it's a mixed bag in which we go. Let's go and protect, do our duties towards the HIV positive patients, but at the same time, do primary duty vis-a-vis isolation of data, vis-a-vis protecting my legal interests, vis-a-vis ensuring compliance with various guidelines that the government has given to us as institutions, as medical practitioners under the HIV Act from time to time. Please remember, the government has been given the power to come up with guidelines, rules under this new law, and it will keep on coming up with guidelines. Ignorance of law is no excuse in the eyes of law. Please ensure compliance. Let's hope that you don't get sucked into the new whirlpool of legal liability, because that may not necessarily be the best solution. Thank you, ladies and gentlemen.
Thanks for helping us on the HIV Act. So I think because of time constraint, we need to. Yes, Dr. Glory.
Mic is not working.
In private practice, when we work with PMTCT, we have very good results, and we don't hardly see any children born with HIV. But yesterday when Dr. Uday Das was presenting, he mentioned that the rate of transmission is about 11.75% in PPTCT. So I just wanted to know, is it because they are large groups? What are the challenges? Why are we not able to achieve zero transmission? Is there any reason?
I'm afraid both Dr. Anuradha and myself, we work and with the care support and treatment
Component.
component. And the PPTCT, I don't know whether it's just someone who works with the PPTCT component at the state level or the SACS or the NACO level.
So I think that part of the problem has been ensuring that adequate testing is being done for the women at risk who are about to deliver. Some of the women have arrived very late and have zero antenatal care and are incidentally found to be HIV positive. And then we've had challenges, and even I personally had a challenge in ensuring that a pregnant lady diagnosed with a latent pregnancy was given appropriate HART as well as the newborn given prophylaxis. Okay? So in the private sector, this is a little bit challenging. But in the public sector, I still think that we have some opportunities for improvement in terms of addressing every pregnant woman and every childbirth to be safe.
Do you have a lot of loss to follow?
So we are tracking that. Yes, there is lots to follow up. And so this has been, I can talk only about our own experiences with sharing. And this has been for us a collaborative effort between the lab division as well as the treatment and care and support division. Yeah, and typically the loss to follow, part of that is migration. But now we become very good at tracking migrants and making sure that we don't have loss to follow. You know, in the early days, and this is something that which is peculiar to India, I think, that a pregnant lady during childbirth goes to her mother's place, Maike, or delivery. And to ensure that those people are tracked and they are actually given the appropriate prophylaxis can sometimes be challenging.
So my question is to Dr. Duggal. You were mentioning about the testing that happens many a times without the person's knowledge even. Many of the employers send a whole panel of testing. And I am a pediatrician dealing with pediatric HIV/AIDS for a long time, and there are many children who are perinatally infected who have gone on to become adolescents and young adults. And because of this very reason, they are unable to get job opportunities. So is this, but they are not supposed to be doing the testing without the legal consent and the pre-test counseling and a post-test counseling, obviously. But for employment purposes, many of these corporate offices and so many companies do the testing without the knowledge of these children. And then when the result comes, they are just out of that, job opportunity. So what can be done about this?
Well, very quickly, if you're doing testing without consent, you're violating the law. But just because everybody else is violating the law should not give you the confidence that this is a new norm and that I won't be caught. In case of a complaint is made against you, well, appropriate legal consequences are going to follow. So, logically, we should not do. If you really want to do that, it's a great idea now to come up with a written final print notice and get it signed by the concerned person. And if you are really very smart and intelligent, put some process in between so that it's not read. But if the guy signs it, then at least you have a legal ground to say, look, I told you so and I got your consent. So should tomorrow a complaint be made against me, I'm not going to be held criminally or civilly liable under the law. But the problem is most of the people are doing it. And it's only a question of lack of, shall I say, implementation of this law. Once this law will be enforced, once there will be more complaints, more and more people will wake up to the knowledge that these legal remedies are available to them. And once a complaint is made, the complaint is made in the government ecosystem. A government file is created. And mind you, it's going to take you a lot of time to get that file out. And the government, if the ombudsman doesn't act, then there are remedies against you and the ombudsman. So I think it's currently being done because everybody thinks it's hunky-dory. It's a new norm in town. Nobody will catch us, so let's keep on doing it. But I think the winds of change have now begun to start blowing. We should be more careful. We should document. In any case, we should protect our backs. So I have a good written notice if you really want to go in that direction, where you specifically even that fine print, you tell them, look, I will be testing you for HIV, and that for this particular purpose, I will give you the consent. If language that regard is available in your notice, that could potentially save you. But if you have nothing like that, and should somebody wake up and make a complaint against you and the company to where you have submitted those results, again without consent, then both of you are going to be hot waters. So I think it's better to realize that in India, people have suddenly woken up to their litigious nature. More and more people are likely to file complaints. And doctors have now become the new fertile targets for the new flavor of the season. Everybody wants to target doctors. Everybody wants to take you to the consumer court, to the criminal prosecution. So it's better that we protect ourselves, document our stuff. Maybe offline, I can help you what kind of drafts can be done. Protect yourself. If you really want to go in that direction as well. Thanks.
Yeah, Vijay, my
punishment for this?
Sure. There's a crystal clear punishment in the sense, if you violate provisions of the HIV Act, your minimum punishment is 6 months. Your maximum punishment is 2 years. But as rejoice, both of them are bailable offences. Where you are entitled to bail as a matter of right. However, that does not take the stigma away from it. Because the moment a case is registered against you, it's going to be splashed online. Once it's published online, trying to get that removed is going to be a Herculean task for you for the next 20 odd years. So I think the kind of reputational damage that this is going to cause is immense. Yes, you can engage a lawyer. Yes, you can delay things. Maybe you will not get integration. But the problem of facing a harassment of a criminal prosecution under this law is going to be pretty bad. But hold on, this is still celebratory times. Wait for the not so good times that are going to come in. Why? Because under the new DPDP Act that the government has passed, should you go ahead and collect the data of these HIV people without their consent, you contravene the provision of the law. You do not go to jail under that law, but be prepared to pay exemplary fines. Under the said law, you can be fined up to 250 crore rupees per one contravention. So that's the new norm in town. And the government says that 250 crore rupees does not go to the complainant. It goes back to the government of India in the form of payments to Consolidated Fund of India. Should you say, sir, I don't have money, I can't pay. The law says no problem, don't pay. But the law will consider that money to be areas of land revenue, and for that particular purpose, the government can come and attach your assets, sell your properties, and sell a variety of other things. So I think they're going to be playing with fire. It's better to be safe than sorry. Thanks.
I have just 3 points to make. Number one, in this act, it is in existence for 8 years. Are there any prosecutions under this act? If no, are there any ombudsmen anywhere? What should be done? Number one. Number two, I found biggest violators are medical community people. Just because of HIV status, they charge double fee for surgery, any procedures, and irrespective of anything, they keep on doing the test. And number three, the problem with insurance.
Thank you, Dr. Yeldandi. Phenomenal questions raised. I am completely in agreement with you. The law has been in place for the last 6.5 years. It's not been implemented. Most of the people are not aware of its nuances. As regards to ombudsman, it's not been appointed yet. However, that does not stop you from going directly to the writ jurisdiction under Article 26 of the Constitution of India, the High Court says, or you can go directly to the Supreme Court with the Article 30 of the Constitution of India. I think medical fraternity is charging more because there is an absence of a legal framework. Once a legal framework comes up, effective enforcement comes up, maybe you will be incidentally. While you have insurance, that's still a very, very great zone. Nobody wants to have medical insurance to an HIV positive person. But the right reasons, including the fact that they should expose the insurance company to unlimited demands of insurance, notwithstanding the quantum of premiums that they want to charge. So I think these issues that have to be regulated, it will take some time. I think it's not a big priority for the government to get, and I think that the government have to see before the enforcement can take place.
Can we please take some questions up?
Yes, just one thing. No patient is ready to come forward. When we say that we are supporting them, come forward and lodge a complaint. When they are removed from their jobs, or when pre-employment testing is being done without their consent, or they don't want to undergo the testing, that time patients are not ready to undergo testing and also not ready to come out in open because of the fear of the larger consequences. So that is why all said and done, practically it is never going to happen. Everything will be only inside this one. Everyone will know about their HIV status. That's what we are facing.
I need to thank all the panelists for their excellent deliberations. And it's already too late now, and I need to close on.
Thank you very much. I request Dr. Guha to hand over the token of appreciation to Dr. S. Anuradha and Dr. Pavan. I request all of you to wait back. We are going to have a quick group photograph. So please wait back for 5 minutes.
अभी कर लेते हैं